Welcome to This Explainer, where we're taking a masterclass level deep dive into the 2026 AHIMA and ACDIS query standards. Today, we're focusing specifically on a highly scrutinized area, the clinical validation of protein-calorie malnutrition and cachexia. Now, if you're a clinical documentation integrity specialist, a medical coder, or a healthcare provider, you already know that the entire landscape of documentation is shifting right under our feet. We're moving rapidly away from simple, volume-driven notes and entering an era of rigorous clinical validity. So we're going to break down exactly what that means for one of the most heavily targeted diagnostic categories in all of healthcare. But before we get into the new rules, let's establish our high-stakes hook. We really need to ask, why are auditors so relentlessly focused on severe malnutrition diagnoses? I mean, why is the specific condition consistently sitting right at the very top of the hit list for recovery audit contractors or RAC reviews and payer denials? Well, the answer lies in the intersection of clinical complexity and massive financial impact. When you put those two together, it creates a perfect storm for external scrutiny. To navigate this complex landscape, our agenda will guide us systematically through 1. The clinical validation stakes. 2. The 2026 AHIMA and ACDIS query standards. 3. Assessing malnutrition and cachexia. 4. Building a compliant query. And finally, 5. Defending the medical record. Let's kick things off with Section 1, the clinical validation stakes. Here's the reality of the situation. Severe protein-calorie malnutrition is an absolute heavy hitter. It triggers major complication or comorbidity, or MCC status, which significantly impacts MSDRG assignment and, frankly, drives up facility reimbursement substantially. Because of this high financial weight, it acts like a giant beacon for external auditors. Think about it. If a provider documents severe malnutrition, but the patient is sitting up in bed eating a regular diet and requires literally no specialized nutritional interventions, reviewers are going to flag that chart in a heartbeat, strip the MCC, and issue a denial. Moving right along to Section 2, the 2026 AHIMA and ACDIS query standards. The absolute foundation of these 2026 standards is clinical validation. This mandate means that a diagnosis isn't just something documented by the physician. It actually has to be supported by concrete, factual evidence or clinical indicators right there within the record. It's simply no longer enough for a provider to jot down a diagnosis in the assessment and plan. Now, yes, the treating provider ultimately decides which indicators confirm a diagnosis, but as CDI and coding professionals, we have to ensure that a minimal threshold of clinical support is visibly present in the chart to validate that diagnosis to any outside reviewer. Now, you might be surprised to learn that a seemingly harmless query title can instantly be deemed non-compliant if it introduces influencing information. Under the 2026 standards, the title seen by the provider absolutely cannot lead them to a specific diagnosis. For instance, if you're querying about a patient's breathing, CDI provider query, respiratory status is totally compliant. But if you title it, Query for Acute Hypoxic Respiratory Failure, well, you've just led the provider. You've rendered the query non-compliant before they've even read the clinical indicators. And the exact same logic applies to malnutrition. Your query title must remain entirely neutral, something like Query Nutritional Status. All right, Section 3, Assessing Malnutrition and Cachexia. When we're evaluating malnutrition, we're looking for the ASPN and Academy of Nutrition and Dietetics Diagnostic Consensus criteria. It helps to think of these in 3 primary buckets. First up, intake and weight loss, which covers insufficient energy intake and the weight loss percentage over specific timeframes. Second is physical wasting, meaning the loss of subcutaneous fat and the loss of muscle mass. And third is functional decline, which includes diminished hand grip strength or even fluid accumulation and edema that might actually mask true weight loss. Typically, a patient has to meet at least 2 of these specific characteristics to clinically validate a true malnutrition diagnosis. To track these criteria practically on the floor, the Mini Nutritional Assessment Short Form, or MNASF, serves as a really vital screening benchmark, especially when we're talking about older adults. This validated tool looks at things like reduced food intake, weight loss over 3 months, mobility decline, and BMI calculation. The key takeaway here is that positive findings on a screening tool like this should immediately prompt a much deeper physical examination and the concrete documentation of those specific Aspen criteria we just talked about. So how do we justify that critical MCC status? CDI specialists must clearly contrast moderate malnutrition with severe protein-calorie malnutrition across acute, chronic, and social contexts. Moderate malnutrition usually represents nutritional deficits that just don't quite require intensive medical intervention yet. Severe malnutrition, however, represents profound acute or chronic protein-calorie deficits that demand significant clinical resources. We're talking enteral feeding, specialized parenteral nutrition, or really rigorous daily calorie counts. If the chart says severe, but the treatment plan looks moderate, you've got a massive clinical validation gap on your hands. We also have to carefully query to distinguish severe malnutrition from related but distinct conditions. Take cachexia, for example. It's a highly complex metabolic syndrome tied to underlying chronic illnesses like cancer or severe heart failure. Contrast that with sarcopenia, which is simply the age-related loss of muscle mass and function. While these conditions share overlapping visual indicators, like muscle wasting, their pathophysiological drivers and their diagnostic coding are entirely different. Clear provider documentation distinguishing these is absolutely paramount for an accurate, defensible health record. That brings us to Section 4, building a compliant query. So what happens if a provider documents severe malnutrition, but the patient lacks Aspen criteria or lacks corresponding nutritional support interventions? Well, you have to construct a clinical validation query, and you need to follow these 4 steps. Step 1, cite the exact location of the clinical indicators or the lack thereof in the chart without adding any of your own subjective interpretation. Step 2, state a clear, non-leading question. Step 3, provide multiple choice options that are actually supported by the clinical scenario. And Step 4, you must provide an out, meaning you have to include options for alternative explanations or the inability to determine. Now, this is absolutely crucial. Relying solely on unreliable lab markers like serum albumin or prealbumin without documenting actual Aspen interventions or specific nutritional support is a massive red flag for auditors. It's the albumin trap. Albumin is an acute phase reactant. It naturally drops during inflammation, infection, or trauma. It's an indicator that the patient is sick, not necessarily a direct, solitary indicator of severe protein-calorie malnutrition. Pointing to a low albumin level to validate severe malnutrition without a holistic clinical picture will result in a denied claim almost every single time. When you build your multiple choice options, they have to be completely objective. As the 2026 standards mandate, you always have to include choices that account for true clinical uncertainty. You should be including options like the diagnosis has been ruled out, the diagnosis is confirmed but with a request for the provider to document the supportive evidence, an alternative diagnosis, other explanation of clinical findings, and, crucially, unable to determine. Including this last option is what ensures you aren't backing the provider into a corner, allowing them to truly exercise their independent clinical judgment. So, what does a neutral query look like in practice? It looks exactly like this. You point straight to the clinical facts, noting the lack of nutritional interventions and the absence of ASPN criteria in the record, and you simply ask them to clarify the patient's nutritional status. Notice how you aren't telling them they're wrong. You're just asking them to bridge the gap between their documented diagnosis and the actual clinical evidence that's visible in the chart. Finally, Section 5, defending the medical record. By shifting away from copy and paste, volume-driven notes, and instead prioritizing true clinical validity and credibility, coding and CDI professionals become the ultimate stewards of documentation integrity. When a chart gets audited, the reviewer isn't just looking to find a code. They're looking to see if the medical decision-making and the patient's true clinical complexity actually justify that code. Consistently applying these 2026 standardized guidelines is what ensures your records can withstand that intense, fine-tooth comb scrutiny. So, it's time to reflect on your own facility's practices. Are your queries truly non-leading? Are your providers actively documenting those Aspen criteria, or are they still falling into the albumin trap? As audits become more aggressive, mastering clinical validation isn't just best practice anymore, it's survival. To keep sharpening your skills, please like, share, subscribe to Decode Healthcare with Harshal.